So I, as a pediatrician, get an electrocardiogram. What would I be looking for? What would I find for that would give me some concerns about putting a kid on or having less concerns utilizing the medicine for ADD?
First thing we need to say is every pediatrician has a different comfort level with electrocardiograms. We as pediatric cardiologists understand that an electrocardiogram is a baseline test that any pediatrician can order without a cardiology consult. There are some pediatricians that do electrocardiograms in their office and feel comfortable with interpreting many of the electrocardiograms they obtain, and those that they do not feel comfortable with, they will often send them to a pediatric cardiologist, like myself, for another interpretation. Then there's a group of pediatricians that don't feel comfortable doing electrocardiograms, and we as pediatric cardiologists have no problem with a pediatrician just referring a child to either our office or hospital for an electrocardiogram, and that electrocardiogram is officially read by a pediatric cardiologist. Other pediatricians are extremely concerned about this problem and will refer the child to a pediatric cardiologist to get a more comprehensive history, physical, and electrocardiogram. So there are many ways of dealing with the electrocardiogram.
If the electrocardiogram is normal, that's no guarantee you're free and clear. It just makes it less likely of a problem. Is that true?
What one has to understand is, as we've discussed, there's nothing scientifically proven concerning the risks of sudden death with these medicines. We, for example, have mentioned the prolonged QT syndrome. None of these drugs that have been used really have been shown to prolong the QT interval. So most of this is evidence-based at a very low level. But because there have been reports of sudden death with children who are on these medications, this recommendation has come about. Now, having said that, let's talk about the electrocardiogram. When you screen a lot of normal people, normal children, you will have things on the electrocardiogram that may be variants of normal. A mild axis deviation, an occasional extra beat, sometimes a little change in the heart rhythm. These are all things that we would call variations of normal. Those children certainly do not require consultation with a pediatric cardiologist if the pediatrician gets that report back. But now there are some things that you get on a screening electrocardiogram. One example, hypertrophy of the left ventricle. Now, hypertrophy of the left ventricle does not necessarily mean that a child has a thick heart muscle. It's only one thing that leads you to say, let's get that child seen by a pediatric cardiologist. Next thing, Wolff-Parkinson-White. Wolff-Parkinson-White is basically an electrical short circuit in the heart. There are people that go their whole lives and never know they have it. But if you screen many, many healthy children and young athletes, you will find Wolff-Parkinson-White on the electrocardiogram. In addition, if you screen normal children, you will get children whose QT interval, what we call corrected QT interval, will be off the normal curve. It will be more than 2 standard deviations out of the normal range. Again, that is not an indication.
What does the QT interval mean?
It means that it's an electrical measurement on the electrocardiogram which increases the vulnerability to a life-threatening cardiac arrhythmia.
What is the heart doing when the QT interval is being interpreted?
Okay. When the QT is there, the heart is in a vulnerable stage. Right? It's in a relaxation phase. And an ectopic beat or an extra beat, which falls in a certain area on the heart, may cause a very, very devastating event. However, most people that have a prolongation of the QT interval are not likely to die suddenly. And it's also important to recognize that the things I've just mentioned, I've mentioned 3 things: hypertrophy of the left ventricle on an electrocardiogram, short circuit in the heart, WPW, and a prolonged QT interval. All of those 3 things would be something that one would say, let's have a pediatric cardiologist look at the child. However, there is nothing to say that even with those findings, the child will be denied use of a drug that they need, specifically the medication